Well, hello and welcome to the Ontario Network of CAPC CPNP Projects Network webinar. I'm really glad to have you here, those who are here in person and those who are watching the recording. Really excited about this presentation, and I'll hand things over to Blanca to introduce our speaker. But before I do that, I just want to take a moment to acknowledge that our Ontario network of CAPC and CPNP projects gives thanks to the First Peoples of the territories where we work and serve. Gratitude for sharing this land that allows us to serve the communities we work with in all the areas where we live. So Blanca, I'll hand things over to you.
Thanks, Sydney, and thanks everybody who's joining us today. Thank you also for participating, if you did, in our Black Perinatal Health workshop series that was facilitated by Mommy Monitor. And it's my pleasure today to introduce Elsie Amoako. She is the founder and CEO of Mommy Monitor and a rising leader in our Black perinatal mental health and just all the issues that we work around to support our Black community. We're really happy to have you, Elsie, and I'll let you tell us more about yourself and about just an overview of what the training was. We had 4 really great workshops facilitated by Elsie, as I mentioned, and Shani Robertson. But please help me welcome Elsie.
I'm very excited to be here today. I'm excited to be able to share some of what we kind of discussed during the workshop series. And as we kind of mentioned, I'm sure Shani mentioned, and I mentioned as well, this information is extraordinarily important for care providers because we're serving populations, specifically when we discuss the Black population, which includes those of African, Caribbean, and Black descent or ethnic origin, whatever that looks like. These populations need care that's very specific to them. And it's important for us to acknowledge that and then to be able to create space and time and actions that serve that purpose. So we can begin. We can go to the next slide. So we've already done the land acknowledgement, so we can kind of move forward to past the agenda. I'll just go straight into the key terms. So during the presentation or the series that we did, we focused on a few terms that were extremely important to understand and just be aware of, and to kind of keep in your repertoire so that when you are serving patients or when you have questions or when you're trying to understand what does equity look like in perinatal care for Black folks, what does reproductive justice look like, what are the social determinants in this space, or cultural safety, like how do institutions remain accountable? Like these are all things that we identified as imperative terms to help us to continue to really pay attention to the way that we serve our community. So I mentioned this during my presentation earlier on, and I thought it'd be important to kind of share the photo with everyone. And we talk a lot about equity and equality and the importance between the two, or the difference between the two. And here I just want to provide a visual for people to visually see why they're different. And then I guess in the next slide, we're gonna go into how it also translates into racism and what racial equity looks like. But then in addition to that, what health equity looks like. So with racial equity, what we're saying is that we're identifying the fact that racism is contributing to major issues in reproductive and sexual maternal perinatal health outcomes. And this is like when we're trying to achieve racial equity, specifically when it comes to perinatal care for the Black community. What we're saying is that we understand that there's injustice in the subconscious and conscious layers of our our systems, our institutions, and our own personal biases. We can go to the next slide. But then we also recognize that health equity through all of that is only achieved if we can kind of understand that not some people are disadvantaged. Not everybody's starting at the same place. And if we can kind of recognize that, then it helps us to understand the circumstances that other people experience and move into a space or create an opportunity to help them to get into a space where they're getting the things that they need and deserve. So we also look at racism as a tool of privilege, right? And what does that look like, right? We already understand that race is a social construct, but we also understand that the problem within care that impacts, or the reason why, or part of the reason why many people, Black pregnant folks, experience health outcomes that are adverse when it comes to perinatal health is because of racism and not because of their race, right? So the problem is racism. The problem isn't that they're Black or that they're immigrants or that they're anything else, right? And I think those are the things that we have to acknowledge, the anti-Black racism that's rooted into our systems, like I said earlier on, and that experience of the Black person, then also understanding that systemic racism is also something that continues to infringe on the experiences of people, of Black people, regardless of where they're experiencing it. So that just means in their daily lives, anywhere they go, specifically in healthcare. And all of this is very much related to policies that continue to perpetuate the same racism, things that never seem to change, things that are subtle, like contemporary racism specifically, which is more subtle and implicit. And there are those negative beliefs and that people have based solely on somebody else's race that you experience. So it's the microaggressions that Black people will experience. It's the look, or the something said very briefly that's not blatantly disrespectful, but the person immediately feels like something is wrong, but they don't have anything to kind of hold to that. So those are those experiences and the ways that we use that racism is used as a tool of privilege, because it's now being used in healthcare to kind of continue to perpetuate these biases that later on do end up putting this population in a position where their health is impacted. So the ways, if we think about different ways that racism can affect perinatal health, this was from Dr. Roberta Timothy, and she talks specifically about children being taken, she talked about the 9 ways, I believe, and she says, well, children can be taken from their families. We've seen that a lot. We've seen that in the US specifically with the Latino children that were put in cages and so on and so forth, but we see it here as well with Child Protective Services, where children are being taken from their homes, primarily from Black homes. Data tells us that Black children are taken out of homes much more than other children, white children in particular. We think about fear of violence and neglect that the parent or the birthing person may experience with the healthcare system. So thinking about that fear that your doctor, your care provider will not care for you, or that they will judge you, or that you'll experience either verbal abuse or some type of microaggression or some type of violence, and that feeling that you will potentially be neglected. Those are real fears that they have every time they go to see a care provider. And then we think about the criminalization of Black persons and their partners, right? There are various stories that I know we told during the training, and you guys have probably heard during your own work, about Black fathers not being allowed inside the exam room, or not being like there always being some type of issue impacting the Black family and that relationship. And during the training, we talked about the history of the Black family and how they were impacted very early on due to slavery, and how they were separated, and how that has then trickled down generations and impacted what the Black family looks like today, but especially the Black man's position within the Black family specifically. We also look at precarious immigration status, right? There are various examples that can be provided of Black immigrants being in Canada, the fear that's associated with that, the instability, and all the other factors that kind of impact their decision-making and their ability to access things to help them to have potentially better health outcomes, right? Like accessing healthcare, right? Having to pay insurance, et cetera, if depending on their status. But then in addition to that, there's also housing, income, and food insecurity, right? Or the stressors of racism. And we talk about this a lot. Stress is a huge component of health outcomes. And we already know that Black women in particular experience stress, I think up to I believe it's 2 to 4 times more than any other group of women, and or probably more actually, and their experiences are directly connected to all of their health outcomes. So it makes sense why they would have the outcomes that they have, considering the stressors that are connected to all the different factors that intersect with their life and their race and all the things that make them who they are. We also think about disabilities, right? We don't talk about disabilities a lot within the Black community, but that is a huge thing that impacts the community. And then transgenerational trauma. And this can be anything from trauma being passed down from the parents to trauma literally from slavery being passed down generations and impacting generations of families until the family that's there today. So these are all various reasons why and how perinatal health is impacted by racism. And there's a lot more, like systems and institutions, like we talked about earlier on, their experience with care, simple things like even how the doctor talks to you or treats you, to accessing care, to wait lists. Like there's a million other variables, right, that can impact care outcomes for Black folks. But these are the main ones that are quite serious, and we see and we have actual data that tells us like these things are happening consistently. So like I said earlier on, it all comes back to history, right? The deep roots of these patterns and disparities in maternal and infant health lie with the commodification of enslaved Black women's childbearing and physicians' investment in serving the interests of slave owners. So we can go to the next slide. This is just, and that's a photo of a Black family, slave family from Canada. But I think that what we don't realize is that our history, the Black history of Black women being experimented upon, Dr. John Sims and the history behind him being the father of gynecology and how he really impacted enslaved women, Black women, by using them as nurses, assistant surgeons, but then also wet nurses. Also, they were also being raped and abused, but then at the same time, they're also being experimented upon all at the same time while they were living with him. So like, and he used all this and other Black women that he experimented on to continue to kind of launch his career in gynecology. And these are examples of what our medicine and perinatal care is based on, right? And the idea of eugenics with Dr. Helen McMurtry. We can go to the next slide. But then we also look at like the 80s and the 90s and the welfare system and crack and how that impacted Black families and Black women, and the criminalization of penalizing pregnancy, right? And the criminalization of substance use and how that impacted pregnancy. But then it just Black women being punished essentially for keeping their children, right? Whether it's keeping them when it comes to child protective services, or if they were incarcerated, or if they were on welfare, whatever their experience looked like, if they chose to keep their child, they were deemed as villains that were negatively impacting the society. And like, these are more ways, and I'm not going to go through all of them, but how slavery impacts us today. And there are examples that we provide before, like the carding system and like sundown laws, and kind of like the correlations between those, to things like the Black family, like I said earlier on in slavery, like the Black father, if there was what they call the stud, a Black man whose structure that they desired and they liked, and they thought he was a great slave, and he physically was the type of slave that they wanted, they would sell him, basically kind of pimp him out and have him go from house to house within the area and have children with other slave women, just so that he could reproduce more children. And Black couples were not allowed to get married. They were not allowed to keep their families because they were separated and sold in different places. The women couldn't nurse their own children. So a lot of Black infants died. There was a very high infant mortality rate during this time. So because they were too busy being wet nurses for the white slave owners. Like, there's a lot of things that impacted the Black family during slavery. And we see all these things today in the way that Child Protective Services removes children from the household, the way that Black families are separated, the way that, like, all of the above, right? The way that Black parents are impacted, like how quick people are to call Child Protective Services on a Black family, right? Even in the hospital after labor, like, we've seen all these examples and instances, right? So these are all examples, but there are various other ways where how slavery continues to impact the Black community today. But in Canada, what's interesting is that although the population of Black people is continuing to grow, and although we know that Black people continue to have a higher poverty rate, they continue to earn less, even though they're Black women are more educated. They're experiencing the most amount of violence, whether it be sexual, physical, whatever that looks like. We can go to the next slide. And then they also have the most increased experiences or risks to various diseases, whether they be chronic or cancers or fibroids or STIs. But then when it comes to perinatal health, we also know that they also continue to be the ones that are most likely to experience complications that can be life-threatening. And we see this in Canada. And again, although we don't have race-based data in Canada, and although we don't have or readily available race-based data, and although we don't have evidence that tells us very clearly, like the US, like the UK, and other countries that have managed to kind of collect that data, we have enough that tells us that it's the same experience, right? And Black mothers continue to have shorter pregnancies, higher risk of preterm births. They continue to experience lower quality care. And then their infants, much like history repeating itself, they continue to be 3 times more likely to die if they're cared for by non-Black doctors, specifically white doctors, is what the research has shown us. And the most frightening part of this is you think about Dr. John Sims in history, and you think about historical forms of like a medicine historically, when it was taught in those books, and how they said Black people don't feel pain, their skin is very thick, and all these teachings that were kind of perpetuated at the time and kind of passed down for years. And although they may not be taught today, they for some reason is still an understanding that a lot of clinicians hold. And because of this, Black women are ignored. That idea that Black people don't experience pain as much, or that they'll be addicted if they're given too much pain medication, so they're not supposed to be provided some. So like all of these things have impacted how they're treated and how they experience care and what their health outcomes look like because of that. And because of that, they continue to have the most severe maternal morbidity and pregnancy-related deaths, right? Especially regardless of what it's associated with. And this, again, like we said earlier on, goes back to the fibroids and how that also connects with weathering and the experiences, the continued experience that Black women have connected to stress and discrimination, and how these things impact their health, and the fact that it doesn't matter how educated they are, how much money they make, or anything else, as much as we kind of explore the social determinants and we understand those factors heavily impact their health outcomes, also understanding that it's also the complete opposite, where everything could be right. They could be as educated as one should be, or wealthy and healthy, but they can still have these same health outcomes. And those are the questions that we really need to ask today. And a lot of it has really come back to how are they being treated when they receive care? Because even the wealthiest person, I think I used this example before, Serena Williams, even Serena Williams, with her very amazing health, fit body, wealth, everything, she has education, when she told her doctor she wasn't feeling well, they still didn't listen to her. So that, I think, is the key in all of this. So outside of all of that, we also know that like the postpartum experience of Black parents, Black perinatal, Black pregnant persons is also quite sad. It's really fearful, actually. When you think about it, their experience with postpartum depression, and then obviously the stigma connected with that in the community, their inability to take time off. Some moms have to go, or pregnant persons have to go right back to work, so they can't spend as much time at home healing, and they don't have sometimes support to help them to get through it. So a lot of the times they have to throw their anxiety or their emotions or whatever they're feeling, their mental health, they have to put in the back of their mind and kind of just live day to day, because now they have a family to take care of. And those are some of the things that we see consistently, especially in our work at Mommy Monitor. And like I said earlier on, we talk a lot about the social determinants, and a lot of them do predispose Black pregnant persons to various things. But again, a lot of this really comes back to the care that they receive inside care institutions, right? And this risk just increases, right? It increases regardless, because of the lack of care of services that professionals offer, the lack of appropriate support, the lack of cultural an ethnic or religious understanding to provide support, and the economic capabilities that they have or do not have, and what they want to achieve as parents for their family. So this is just an example that we created that kind of gives you an idea of all the systems, institutions, the things that impact Black perinatal health. We can go to the next one. And here's another one that I thought was really interesting that kind of explores like Black women. And these are all of the kind of illnesses and experiences that they tend to end up more susceptible to. We can go next one. So why is this happening? And I think like we talked about it earlier on, care services are fragmented. We're not paying policy-wise, we're not paying attention. The ministries are not really paying attention, specifically not to Black perinatal health. And we're not having that dialogue about Black perinatal health like they are maybe in the US right now. We can go to the next slide. And a large part of this is like the long wait list, specifically for obstetric care. And we also know that they've shown us as well that there's a larger supply, or less is the supply of midwives and OBGYNs, right? There's not as many as we have much. If you see, Canada has the least amount at the top of the list. So we're obviously in a state where we don't have the resources and we don't have the professionals needed to serve our communities. And that is a huge issue that I think is brought up somewhat, but then it makes you think about midwifery care and why there are so many issues connected with that around like the number of patients they can take on in a year, or their funding, or all those other things that kind of impact their ability to care for people. And how many students are being admitted into medical school versus those who are not being given residencies, and who's coming, the IMGs that are coming in, and whether or not they're getting support to kind of be able to work here. Like these are all questions you start to have over time. Like why are we contributing to the problem as opposed to opening doors to make it more accessible for care professionals to be here to provide care to people who need it? So how do we make changes? And I think that as a care provider, it's important for care providers to kind of not reinforce stereotypes about Black parents, right? So don't make assumptions. If a Black mom's alone, don't make assumptions that she's uneducated, or that she is low income, or that there's a Black father, and understand the implicit and explicit biases that are connected to sometimes a lot of the thoughts or the things you may say or your actions, and how a patient will catch on to that. Because I think the key thing we have to remember is that I think sometimes when you have a thought or a bias within you, and you're thinking of something, or if you say something a certain way and you're trying not to offend or whatever's going on, that turns into a microaggression, because the person has had that experience multiple times and they know what you really mean when you're saying what you're saying, right? So as much as you try to like kind of make it seem like it's not what it is, it's still interpreted as exactly what it was meant to be. Next slide. And I think this is why we go towards birth justice. So if we are creating or providing work that is based in birth and reproductive justice, where we understand that these people have the right to have children, the right not to have children, the right to parent, the right not to parent, that we are empowering them during their pregnancy, their labor, their childbirth, we're helping them make healthy decisions, provide them with resources to continue to take on those decisions, and dismantle inequalities around race and gender, sexuality, all these things that put us in positions where we have those implicit and explicit biases that impact the way we treat patients and impact the way care is provided. If we can just kind of start with reproductive and birth justice, then I think we're in a situation where we can move towards really positive change. And like some of this looks like, especially with reproductive justice, like, are we providing access to reproductive health services? Are we providing education? Are we telling patients that what their birth rights are? Are we accepting, right, decisions and providing them access to decisions around access to birth control? Are the patients receiving adequate access, right, to prenatal postnatal care? or do they have the wages that they need? And this part becomes a little tricky because sometimes you don't want to get too involved, but it makes the difference sometimes when you just, if a patient is sharing something with you or is opening up, or if you're noticing something and you know that maybe you can connect them with the social worker in the hospital or whomever to just kind of help them out with their situation, that makes a huge difference sometimes, right? Or if you're just providing them with information of where they can go and what they can do, and letting them know what their informed choice and consent looks like, what is that? And so that they know that they can say yes or no to a treatment or to a procedure, like that makes all the difference in the experience of the patient. And when we talk about informed consent, we have to realize that that just means that we're giving them the freedom to make choices about their care, right? And we have to realize that the patient should be in charge of the decisions that they make, not the provider, regardless of what the provider thinks at that point, right? And that they have the right to refuse anything, and they have the right to withdraw consent from a treatment, and that decision that's been made needs to be respected. And I know there's a lot of ethics around this, because what if somebody isn't in a state where they can make decisions, or if they don't have any family members around and the provider has to make decisions? We've seen 1,000,001 different scenarios in bioethics around this, around what should be done or what could be done. But I think that in the case of patients who are competent and we know can make decisions, this more than anything else stands, and they just need to be respected in decisions that they make, because people understand their bodies, whether or not we want to believe that, right? And another way to look at this is just accepting patients' birth rights, right? And the National Black, I think, Association for, I don't remember the NAABB, I don't remember the full name right now. I think it's something birth something, I don't remember it. But the point is, they created these amazing different kind of photos where they were just displaying what the rights of Black patients are, right? So what does a Black patient expect? They expect you to respect them. They expect you to allow them to be in a position to make their own decisions, to recognize their humanity, to ensure that they're seen and heard, to inform them of their pain relief options, to believe them if they say they're feeling something, right? Or they're experiencing something, to allow them to choose who's their tribe, as in who will be around them, who will support them during this experience, and giving them the opportunity to be informed about everything that has to do with them in their procedure. And that means not just informing them, but informing their partner, or whoever's there to support them, or their doula, or whoever is in that space who's there for them deserves to have this information. And I think I've heard multiple times that sometimes care providers are annoyed when doulas are asking questions, but I also think it's important to realize that if within reason, if that doula or that support person in that space for that pregnant person is asking specific questions, it's typically for a reason. It's typically for the best outcomes of that patient. So it's important that we work together to make sure that patients have everything they need to have the best possible health outcomes and best possible pregnancy and labor experience. So as a care provider, the other questions are like, okay, so what can I do as I'm a non-Black care provider? What can I do? And a large part of this is understanding how to be an ally, right? Understanding your privilege in that position, and understanding that the goal for you is to try and make the world more equitable. So recognizing where inequities are, and recognizing that you're in a position, a power position, where you can support to make substantial change, right? And a large part of this, or the first step of this more than anything else, right, is combating racism, right? Which means not pretending that like you're colorblind, not acting like you don't see race and like these things don't exist, because they definitely 100% do. And I think that's what's key. And then in that, being aware of unconscious bias, right? Next slide. And in that, just realizing, so in your unconscious, when you recognize you have unconscious bias, right, then you realize how that could potentially cause or lead to racial discrimination. And if you can think about how that can impact the patient, it helps you as a provider better understand how you can kind of adjust the way you speak or the way that you motion or the way that you engage patients to ensure that they're not in a situation where they're experiencing more stress or that they're being denied access to healthcare resources or any of the above, right? That can cause them to be in a space where they think or they know that they've experienced negative treatment. And I think that more, again, going back to implicit and explicit bias, right? We talk a lot about that and what does that look like and how does that show up in medicine and how do you know if you're doing it? And I think that I believe there's a test that you can check online if you Google, but I think that anything else, more than anything else, just kind of putting yourself in the position of the patient and realizing that it is, if you just kind of pay attention to observe your surroundings and observe the way that other people are caring for patients and the patient's experiences, you will see that a lot of people are being judged according to their ethnicity and their socioeconomic background, right? And they're facing discrimination to that. In the initial training, I gave an example of our maternal navigator. She's a perinatal nurse, and she worked in Brooklyn. And she talked specifically about like literally seeing a young Black woman come in pregnant, needing care, and them having her sit in the ER for the entire day. They go up to her once at some point, ask her if she has insurance. She says no, and they left her there for the rest of the day. And their assumption was she's a young Black mom. She has no money. She has no insurance. We're not going to care for her until the end of the day when things got very serious and they had to kind of rush her into surgery. But like it shouldn't get to that point where someone's life is at risk before we're paying attention, right? But at the same time, that doesn't mean that you need to be the white savior, right? And your job is not to rescue Black people, right? Your job is not to impose your standards on them or to kind of like do anything that creates a situation where you're demonstrating pity or any of the things that can make somebody feel less than while engaging with you. And that's where we lead into what we've been taught: cultural sensitivity, cultural competency, cultural safety. And I think that we're moving away from cultural competency because it's never a good idea to be competent about somebody else's culture and just kind of using that term to where the assumption is that you're just okay with the situation or that you're content with it. Like those are not things that we should be aiming for or striving for as people who are caring for people. More than anything else, we should be moving towards a space of cultural safety, right? Where we're saying that we are going to respectfully engage patients and we're going to recognize and address the power imbalances that are there and that are inherent to the healthcare system and really serve the patient according to their specific needs and outside of the generalized approach and generalized assumptions that we make about patients who look like them or who have the same ethnic background as them. And here's an example, right, of us moving away from cultural awareness, sensitivity, competency, and safety. And I always say it's like us moving away from being polite and being realistic about the situation and actually make self-reflecting and taking actions towards really advocating on behalf of our patients and clients. And another way to do this is by being humble, right? And by demonstrating cultural humility. And if we're able to challenge our own cultural biases and realize that we don't know everything about everyone and that we don't need to, but we can kind of situate ourselves to at least be kind and to be understanding and respectful of individuals and understand that there's a difference, but there's still a sameness in that difference, then it helps us to approach learning in a different way and look at this as a lifelong goal as opposed to us trying to figure it all out at one point. And again, just kind of re-emphasizing the power imbalance, right? And realizing that in your position, there is a power imbalance, and that especially people from countries, people who are immigrants that have come into the country, they specifically look at care providers in as powerful figures, right? And everything you say to them, they'll believe for the most part, and everything that you say, they'll take to heart. So think about that. It's kind of like having a child, and the child believes in everything that you say because they trust you, your own child. And you don't want to lead people or stray them in the wrong direction, or give them information that can potentially be of harm to them because you didn't take time to understand the full scope of their experience and their situation to serve them and find better ways to assist them in having the best possible health outcomes. And this is especially important when we talk again about female body people, racialized persons, especially when they're in white spaces, right? And we don't talk enough about the white space and what that experience feels like. And whether it's public or private, enclosed or not, there is an experience that is unlike any other as a Black person in this country, or in any Western country really, where you're incredibly self-aware of who you are amongst other people, of what people think of you, of people looking at you, of how people feel about you. You have to be aware of yourself. You have to be aware of others. You have to be cautious of others. You're constantly in a protection mode. You're constantly just thinking about how you act and how you react to things because of fear that something could happen to you if somebody misunderstands what you're saying or your tone or your actions. Like, all of these things are things that are thought about consistently, in addition to everything that happens in real life. So whether or not they have to be at work, whether or not their kids are at daycare, or if they have to pick up their kids from somewhere, whether or not their partner is happy or unhappy, or whatever is going on in their life, right? Whether or not they can pay the bills, whether or not they have to send money back home. Like, these are all things that a lot of Black people are consistently thinking about, in addition to experiencing racism, microaggressions, and all these other things, and thinking about themselves and how people feel around them for the entire day, every single day. And like these are not small things, but things like telling people to even like thinking about their accent, right? Does the doctor understand me when I have a conversation with them? Or like thinking about like, oh, do I not wear my ethnic dress, right? Do I not cook this type of food because they think it smells? Like, these are all things that are thought about, that have to be acknowledged, because as much as they could seem like trivial matters to somebody else, like just change your clothes, or just don't make that food, or just don't whatever, to that person it's offensive and it's painful, because those are parts of their identity, right? And this is where, outside of having individual accountability, the institutions need to begin to also have accountability, right? They need to be held accountable and change these power imbalances, right? But then in addition to that, they have to, and we talk a lot about now specifically in healthcare, include diversity and inclusion and what that looks like, and trying to hire more people who are more racialized or look more like the population, whatever that looks like. But I think more than that, it's not just kind of giving people positions, because there's jokes now that people make. They're not good jokes, but it's unfortunate. But a lot of Black people were hired, or racialized persons were hired during COVID in companies because of the drastic realization that they needed more racialized people there to kind of help them in a system to serve communities. And as soon as things are now starting to kind of, they're not dwindling down, but I think the assumption is that they are right now with COVID, then they're firing those same people. And so if we're going to hire people and bring them into the space to assist with cultural safety and humility in healthcare, we really have to be true to that investment, be open to it, and trust the people and allow them to do their work. And then advocate as other individuals. We have to advocate on behalf of those individuals to create more space for people like that to access the institution, and then create more community partnerships, right? And engage communities in a better way so that we have the opportunity to really hear what the community wants, so we can make decisions institutionally that serve their actual needs. And when we do all of this as a way forward, how we make those changes, disparities are reduced when we can increase access, when we can maintain that access, right? That means people are continue to come, and it's not just a short period of time, or they continue to use those services. If we really understand what patient-centered care is and actually provide that, when we address people's full experience, right? Everything, all the things that intersect with their race and their experience overall. And then we expand access to quality and comprehensive reproductive health care, and so on and so forth. Like when we do all of this and invest in cultural safety, we can then see a huge change, right? If we're not generalizing care, if we're approaching policy, like examples from the US, like the Black Maternal Health Mommy Bus Act, or developing committees that can really, with experts that can really fight on our behalf, like the Black Perinatal Health Caucus in the United States, like these are all ways that we can kind of really move forward. And what is great is that the Black Mamas Alliance, they wrote a paper and they kind of broke down 8 standards that are essential to change, right? So that we can care for Black women and Black pregnant persons better. And the number one thing was listen to Black women. And I said earlier on, Black women are not listened to, they're cared for least, they're given the least amount of attention, they're not provided medication when they say they need it. There's 1,000,001 stories I can tell you about Black women who are pregnant and were said, I have a headache, I don't feel well, and their midwife or their doctor completely ignored them and they died during childbirth or before even labor. So and this is today, like in year 2020, 2021, 2022. So listening to Black women is huge. Again, trusting that they know their bodies, trusting that they know what's happening to them and how they feel, and taking time to explore that. But also recognizing historical experiences. So we talked about history a lot and how that's impacted the Black family and Black women and Black pregnant persons. So just kind of not having, obviously, to be a historian, but just understanding that there's something there, the foundation there is connected to a generation of pain and trauma that's continued on in medicine and continues to impact the way that they receive care today. But then also just thinking about providing care through a reproductive justice framework. Like I said earlier on, really paying attention to birth justice and reproductive justice and acknowledging that and the importance of it, and using that as a way to really support and serve Black pregnant persons. But then in addition to that, just being able to disentangle care from racist beliefs in modern medicine. So acknowledging anti-Black racism, acknowledging racism embedded in our systems, in our institutions, and trying to make efforts to move away from those practices and those biases, implicit and explicit, and being open to change. But then replacing white supremacy and patriarchy with a new care model. So these are stuff like, this is something we do at Mommy Monitor, where we focus on our full circle of care, and we really acknowledge the importance of having the actual family and social services in addition to clinical services and other supports, and mixing it all together to give people the best care teams possible, to give them the best possible chance at a healthy outcome. And in addition to that, empowering patients with health literacy and autonomy, right? Understanding their birthrights, informing them of their birthrights, respecting their decisions they make, understanding, giving them the opportunity to understand that they can have consent, and having informed consent, and all those things that kind of impact the decisions that they make, and giving them seats at the table so they can make decisions that impact their health and the health of their communities, right? But then also empowering and investing in paraprofessionals and recognizing that access does not equal quality care. So I think this is great for Canada because we're known for having quote unquote free healthcare, and we have a multitude of services that people don't use or attend when it comes to prenatal health specifically. We don't have anything much for postnatal health, but really prenatal. But like, even with that, just because there's access, it doesn't mean people go. It doesn't mean people actually have access. What does access mean? So every care institution, whether you're a CHC or midwifery clinic or whatever that looks, a hospital, this really exploring what access means for you and the jurisdiction in the community you're in, exploring if your community actually feels like they experience access, and then trying to understand how you can create access for them that is directly connected to what it is that they actually want and need, and actually serves their true needs as a community and as individuals. So yeah, that would be it. But if anyone has any questions, I'm open for that. I think we have like a few 2-3 minutes for that, if even, and we can go to the next slide. If you guys have any patients who want services, we offer all of these, and you can kind of book them on our website, or you can email us at info@mommymonitor.ca. Check out our social media and our website for more information. We're rebranding right now, so there's gonna be a lot of changes soon. And last slide is our social media, any information you need to contact us. So yeah, if you have any questions, I'm here. If not, it was a pleasure sharing with you guys today.
Oh, let me let people unmute themselves in case somebody wants to come on video or ask. I want to thank you, Elsie, for that amazing summary. You mentioned Googling a test around implicit bias, and I think, were you referring to the Harvard implicit bias? I'm happy to put that in the chat. I've visited that before, in case people are interested. It's a really interesting process, and I think great resource for some self-reflection.
Yeah, and I think it's important to note as well, everyone can have implicit bias, right? You don't have to be white or Black, but like everyone has bias in them, whether implicit or explicit. So it's important to kind of just understand what those biases are and then work on them.
Yeah, absolutely.
Hi, Elsie. Thank you so much. Thank you for the presentation. It's really, I'm going to actually put my camera on so you can see me. Hi. Yeah, thank you so much. This was very informative, and well, you know, it's really what's the word, it's even more than sad, you know, like knowing that there's a lot of people are going through all of these, and there's still no acknowledgement, right, from the institutions. And I have also heard stories from, you know, from other ethnic groups as well, that it's just not okay. So thank you so much for sharing this presentation. The question I have, so what are the services that you could offer to community members?
Yeah, so we offer everything, and we're expanding, but right now we offer, so we have access to midwives. So either we help people find midwives if they want to find a midwife, or we give them access to a midwife to ask questions and talk to them. If they don't actually take them on as a client at that point, that's more just like if they have questions. But if they want to take them on, we can also support in that. We offer doula care, pelvic floor therapy, mental health support. So we have a clinical therapist. We offer, there's a lot more. I don't remember all of them right now, but everything.
Yeah.
Basically, but we do have everything. Like we have a new, for example, sometimes if there are immigrant parents that we engage and they need help even acclimating to society, we try to support them by identifying immigration services and other things that can support them to kind of figure out how to live in this Canadian society. So really, we, like I said, we customize care to each patient, each client, depending on what their needs are. Great.
And how's is there a referral process? Do we have to get in contact with somebody at the organization through submitting a form, or how would that work?
Our intake forms are on our website, so you can just fill it out, and we have either you can refer as a institution or as a care provider or social services provider, or the patient can self-refer and sign up themselves.
Oh, okay.
It's either or, whatever kind of makes them comfortable.
Oh, that's wonderful. That's wonderful. Excellent. Well, thank you so much. I will definitely keep that in touch. And yeah, definitely we could perhaps in the future have a conversation, a chat, and see how we can do some partnership with the program. I am with the Stop Community Food Center,
Oh,
I'm
cool.
the senior coordinator for the Healthy Beginnings program. So we do have a lot of participants that might be might benefit from your services. So yeah, I'll get in contact with you. We'll keep in touch.
100%. Yeah, please do. We're starting to really formalize all of our partnerships. We have partnerships with a lot of CHCs and different people. They send their patients to us all the time. So it's great knowing that we can really help people and that people are actually happier after. Like, and the stark difference is amazing. And knowing, and I think I said this during the first training, when I saw the difference between literally saving someone's life and living and dying, I realized that what we were doing was efficient. We were actually helping people. So I'm always happy to kind of continue on in this work and help more people.
Absolutely. Yeah. Thank you so much. Nice meeting you, Elsie. And yeah, we'll keep in touch. Thank you so much.
Thanks.
Elsie, I was wondering if you guys do this type of awareness, educational workshops or I don't know, teachings for health professionals. I know that Shani,
Shorter one.
she's with Sick Kids, right? I'm not mistaken.
Yeah, so she works with us, but she also works with Sick Kids, but she does these trainings with us specifically. So we, as a part of our curriculum, we have shorter workshops for healthcare professionals, and we also customize topics. So if there's something that they really want to learn, we'll customize our training because we have a bunch of different trainings, and we'll just either take from our pool or create a new one and customize it for that group. But we do everything from like the training that you guys saw was a little larger, I guess you could say, because it was for like a series kind of, but we do shorter ones, like an hour, 2 hours, where we kind of go through stuff. And we also do longer series where we do multiple short sessions with groups.
That's great. It's really, it should be part of every curriculum, you know, for health and social services, everybody really, because it's such an important piece. Thank you.
Thank you, Blanca.
Okay. Any other final thoughts or questions for our guest here today? I want to thank you again so much for your time and taking us through that. I know it was a massive amount of information, and I don't know, I thought you just did a great job of sort of pulling out those main points and sharing that with us. And I know I heard a lot of really good things about the 4-day training, and so I was really glad to get a sense of what was offered there. And yes, hopefully we'll have more opportunities for this kind of information. Yes, so very important. So thank you so much. And thanks to everybody who joined in today. And Blanca, do you have any last parting words for us?
Just once again, Elsie, to thank you and Ephra and Shani, who were also part of coordinating and presenting, facilitating the 4 workshops that we had. And yes, we had really great feedback from everybody who participated. And you know, I'm really hoping that we're able to build on this. So we're going to be looking for opportunities to do that in the future. So thank you once again, and let's stay connected. Let's stay in touch. And look out for the Racialized Maternal Health Conference, right? Coming up sometime soon.
Blanca is like on it. Yeah, we're planning the conference again. So we're going to have it in 2022. It's going to be amazing. So just everyone get ready for it. It's going to be really good. I'm very excited.
Awesome.
Yep.
We will keep an eye open for sure.
Thanks, everyone. Have a great day. Bye.
Thank you, everybody.
Take care.
Bye-bye.
Everybody.
Bye-bye.
Take care.